available promptly, then they continue to try in the hope that it will come. Unfortunately, it doesn't come, and the longer the baby stays stuck in there, the more likely she is to develop fistula. So fistula itself is just a hole that develops between the birth canal and the reservoir for urine or the reservoir for feces. There shouldn't be any communication between these two reservoirs and the birth canal. But when the baby's head is stuck in the birth canal for more than 6 hours and over, sometimes it runs into days, then fistula develops. And
but
this is the reality.
at that time, the mother is in distress. So
yes,
why not take her out of that distress? Why wait so long?
It's the understanding that they have about labor. It is the belief system, the culture, the tradition. So there's so many religious connotations to labor and delivery, and to somebody's world, you have to be delivered at home. So they try their best to be delivered at home, and generally, mostly, it's just to prove that yes, I have arrived and I'm a woman. That's about all it proves.
Let's talk about the causes.
Okay.
What makes it a woman susceptible to getting fistula?
Usually we look at the height. For instance, if you take women who are less than 1.5 meters tall, typically if the baby is more than average size, that baby will have a challenge coming through. So the height of the woman is one thing to look out for. The second thing is...
So in plain terms, you're saying if you are taller,
you are likely to get away with a normal birth. If you are taller, you are most likely to get away with a normal delivery. But if you are short or in short stature, then it can be tricky. It depends now on the size of the baby. And so if you are not sure, the best place to go is a hospital where cesarean section is available. And in that process, if the baby has difficulty coming through, they will resort to an emergency C-section to deliver you safely. Apart from the height of the woman, you find that naturally, if we don't know how the baby is turned in the womb, you may go into labor and meet a surprise you didn't expect. And normally it is easy to deliver a baby if the head is coming first. But it could happen that the baby is coming with some other part first. And those other parts first can only be delivered in hospital and usually via cesarean section. So it's also about how is the baby presenting. Then one other common cause is the size of the baby generally. As women deliver more, sometimes the babies become bigger.
Why is that so?
It's one of the observations, and for some women they are the same size, some is smaller, but generally as the woman delivers, the higher the number of births, sometimes the bigger the baby. So you find that you may succeed with baby 1 at home, baby 2 at home, but baby 3 may be different. So you find that you get to that stage and then the baby cannot come out. And so when these things happen and the woman keeps trying to deliver away from a health facility, then the chances of her developing a fistula becomes very high.
What about those who may be born with some form of abnormality in their reproductive structure?
Yeah, that's a different scenario altogether. And most of those have other signs other than fistula. They have more than fistula. Obstetric fistula is typically those who have been born normal and have everything okay until they were going to labor and delivery.
What does age have to do with it? Because there have been the dynamics about marrying girls too young.
Yes.
And then they having to develop fistula because of prolonged childbirth.
Yes. Now, if we accept that the women are in areas where they don't have access to emergency obstetric services, then we can say no to child marriages and absolutely no. It's not a good practice, but traditions are difficult to eradicate. I keep saying that in the developed world, there are as many teenage pregnancies, if not more, than you have in sub-Saharan Africa. Yet they don't have obstetric fistula. Why? Because there's access to emergency C-section. So they may have young people getting pregnant, but when their labor is difficult, they have quick access to emergency C-section. In our part of the world, emergency C-section is not promptly available countrywide, depending on where the woman is located and depending on the cultural practices where she's finding herself. In those places, you find that children who become pregnant are at greater risk of getting fistula because their labor may obstruct. Having said that, even if you are aged, maybe mid-30s and above, and your baby is coming with the shoulder, for instance, and you attempt to deliver at home, it could end in trouble. If you are fortunate not to die in that process, you could end up with an obstetric fistula. Sometimes it also happens that the baby may be presenting with the head but can be too big for the woman. So it is not cast an eye on that if you are young you get fistula and if you are old you will not.
Because I was going to ask then, at what age is it appropriate for
It's all about access to emergency obstetric services.
But certainly below a certain age is unacceptable.
Sure, I mean our constitution defines adulthood at 18. So if you're finding someone pregnant at 15 or pregnant at 16, that's a bit much. It's a bit difficult. That's a child having a child. That is very difficult. It comes with a lot of problems. The pelvis is not finished growing. Itself may be malnourished and not well developed. So there are so many problems with that kind of pregnancy. Anemia is a very common problem. So usually when they even bleed, the slightest amount of bleed, and then you find that you are chasing the mother's life. So yes, a certain age is a difficulty, but if they still have access to emergency services, emergency cesarean section, they'll still get away with a teenage pregnancy or get away with the childhood marriage. We are not condoning childhood marriages in any form. At least let the girls grow to be a live birth and a very normal, intact woman.
You talked about certain peculiar scenarios during labor that make a woman more likely to have prolonged labor. That if the baby is not turned right, the baby is too big. We're encouraging our women to go for antenatal. And if a woman is going throughout her term, why should she only find?
I think that's a very good point. 4 times during the pregnancy. But when it comes to delivery, they have their preferences born out of a lot of reasons best known to themselves. Sometimes they are told in the hospital that you cannot deliver on your own. And that alone is enough to send a woman away from the hospital because you have detected that she cannot deliver on her own. And that is why we use every opportunity with programs like yours to keep creating the awareness and laying the emphasis that the best place to deliver is the hospital, because that is where, if things are not going well, we can easily intervene. So yes, we do see some problems during the antenatal care, but when the delivery time comes, then the women opt to do something differently. For some of them, yes, they would wish to go to hospital, but just the circumstances of the environment where they are living make it very difficult for them.
Right. I want to share a scenario with you, but before that, those of you who are trying to call into the line, you can only send us a text or a WhatsApp message. The number is 0245-780-116. If you have any question about the management and treatment of obstetric fistula, send to that number. Later on, we'll open the phone lines, then you can call in. The scenario I wanted to paint to you was an experience that I had with another mother, potential mother. And she tells me that at the time she was going to deliver, she didn't even know that this baby was in the breech position. In fact, she didn't even understand what breech meant. And then she was told by the medical personnel that if she did not do the cesarean, she would end up having fistula. And she insisted because she didn't know what breech was. And so she just moved on to another facility. And by the time another doctor picked up her file who did not know, you know, I have a breech baby, because she didn't understand it and she didn't understand how serious it was, and she didn't even know what fistula was. She allowed the process, and unfortunately the baby died.
I see.
So how do scenarios like that happen in this country?
Yeah, this is one of probably quality of care, because now she's changed facility, and the second facility they did not detect the breach. It has to do with the quality of service in that second facility, and all of us trained at least should be able to pick that up. Now, even if that was missed and she went into labor, it's a bit strange that they could not safely deliver her, and then she has to end up in a fistula. That presupposes that the skill set in that particular facility leaves a lot to be desired.
There's another scenario of a mother who was carrying twins, who goes to a facility that provides antenatal services, but this is a private facility.
Okay.
And there's a scan on the babies, and the scan shows nothing.
Okay.
Later on, she finds out that from the second facility she went to. But from what they were telling her, the first facility gave her the scan that it was authentic and that the babies are fine. Apparently, the babies were in distress.
Okay. These are beginning to look like obstetric case scenarios that
how are such health facilities even being allowed to operate if you don't have the adequate machine to have a clear scan for a potential mother? You shouldn't even be allowed to be operating.
These ought to be brought to the attention of the facility managers, because there are quality assurance teams in all the facilities. And so when things like this happen, when lapses or mistakes like this occur, they investigate, and then they take the appropriate action to make sure it doesn't happen. We all do our best to minimize errors, human errors, to the barest minimum. And so some of these things, it's best to draw the attention of the facility management to it. Nobody jokes with mother's pregnancy and labor. So any lapses are quickly, thoroughly investigated, and then the appropriate interventions put in place to forestall any recurrence. So I think it's very important that the managers of these facilities are are made aware. Sometimes this information, it floats on social media and it doesn't get to management. So it's difficult to, unless you approach the management with your complaint formally, and then they may look into it. Because you see, we are here talking about fistula, but the quality of care in the facility is also important if we want to end obstetric fistula. The timeliness is also important.
What are the types of fistula? How does it present in different forms?
Yeah, usually we commonly will talk about vesico-vaginal fistula, which means the woman has that abnormal communication between the reservoir for urine and the birth canal. So it's urine that leaks out. It's urine. So there's one type where urine leaks out. There's another type where it is the feces that leaks out. And there's a third type where it's a combination. They have both. That tells you the level of injury and the degree of damage that may have occurred.
And when it happens like that, is the woman able to control her edges?
No, she doesn't control anything. She loses all. Now, I was diving into the days or the realms of the patient. Once they notice they are leaking urine, I told you before, they stop drinking. And that has lots of problems, creates lots of problems for them health-wise. We are 70% water. So if you deny yourself water, ask what are you doing to your body? Or they starve because they know if they don't eat, they will not leak feces. So they starve themselves, and you need food to move on. So you find that they become very ill and chronically looking malnourished. And if anyone is listening that has any links to a fistula patient, please encourage them to drink, because despite that they are leaking and they worry about how they will keep themselves from getting wet, a lot of them will cut their own clothes into pieces and use them as rags to keep themselves from being wet. Then they wear several layers of shorts before they put on their dress, even if they are home, because they want to hide the shame and humiliation of leakage. Some of these make them even worse, because the several layers of rags and shorts keep urine in contact with the skin, and that urine in contact with the skin, particularly concentrated urine, it damages the skin. So we always advise that either shea butter or Vaseline should be applied copiously to the genitalia or the genital area, so that even if urine touches it, it will just drop off, because you know shea butter is oily and urine is watery. Encourage all fistula patients to start. Not only even fistula patients, some women, when they cough, sneeze or laugh, they leak a bit of urine. If you are in that category too, it's important to apply lots of shea butter or Vaseline, so at least you keep the skin protected, because sometimes even after the fistula has been cured or the surgery has been done, it takes months to years for the skin injury to heal, and it lowers their self-esteem, and this is something we need to encourage them to try and avoid. For the fistula patient, because of the leakage, if they have to step outdoors for any length of time, they have 2 bags, one for wet clothes, one for dry clothes, and they calculate carefully how far they go, how long they stay, and their life is one of always looking out for privacy and washroom to go and change in case they feel wet. So their life is a very challenging one.
You talked about some women having to cough and sneeze and licking urine.
Yes.
Is that also fistula?
That is not fistula.
Okay.
That is a different type of incontinence. It's also leakage of urine, but it is not fistula. That is very common with women in the menopausal ages. And so, yes, for those as well, there is remedy. Don't assume it's just part of aging or it's part of childbearing. Please get to a hospital. There is remedy for even those conditions. But I put it in because generally, by the time you've seen them, you find that the skin damages are extensive, and that takes time to recover. And so, but you can easily just save yourself from those if you apply a lot of shea butter, a lot of Vaseline to the area, so that even when urine drops on it, it doesn't stay, it just falls off, and then you keep your skin protected and your self-esteem remains intact.
What about the smell?
The smell is a very challenging one for them, but you see, the more they drink, the less concentrated the urine is, and light amber urine doesn't smell. It's usually when urine is concentrated and it's been kept for long that it begins to smell. So the more they drink, the more they leak, but the less they smell.
Let me ask an interesting question, because women usually use their pads during their menstruation.
Right.
Wouldn't they just use pads? Is that not enough?
Yes, you can use an adult diaper, but it comes at some costs. I mean, a pack of 10 could be going for about 30 Ghana cedis, and some of these women cannot even afford 3 meals.
But you can't use a menstrual pad.
The menstrual pad will be too small. We're talking about urine trickling in, water coming.
So it's continuous.
Continuously. Even for adult diapers, some will change it about 3 or 4 times a day.
Right.
So the sanitary pad is woefully inadequate to hold the urine.
Let's now go over to Zoom. We have been joined, and she's been listening in on the conversation by the Director for Gender at the Ministry of Gender, Children and Social Protection, Dr. Comfort Asare, has joined us via Zoom. Doc, what is the ministry's overview of Ghana's situation when it comes to obstetric fistula?
Hello?
Yes, Doc. I don't know if you caught my question, but I'll go over it again. I'm asking, as a ministry, since you have the oversight responsibility, what do you make of Ghana's situation regarding obstetric fistula?
Thank you very much for this opportunity, and good afternoon, Dr. Ganyaglo.
Good afternoon.
The Ministry of Gender is aware that there are women and girls who are suffering from obstetric fistula.
Right.
But for me to talk about the situation now, I don't think I have the data. I tried putting some figures together, but I don't want to mess myself up, so I dropped it because I wasn't getting.
That's understandable. But we do hope that you get that data soon. But what are your plans as a ministry to curb the incidence of the condition?
Yes, the ministry normally takes action when we get reports of women and girls who have been identified to have the condition. For some time now, since 2015, the ministry has facilitated the repairs of 162 people who suffered from obstetric fistula. And the ministry has also sought funds from ECOWAS. We are working on it. We have sent our proposal to the procurement authority for us to release the funds that we've gotten from ECOWAS to Mercy Women Hospital in Mankesim.
Okay.
They have been the center where we normally transport the women and girls we've identified in the districts for them to repair them, because they have a very good facility that can also cater for caregivers. One thing we do is to organize sensitization programs in the various communities. When we organize, then we encourage people who have obstetric fistula to come out so that we can help them. Because of the condition, most of them don't want to come into public life. They don't just come out. They keep themselves indoors because they are stigmatized, they are marginalized, and they are very, very vulnerable. So the officers have to go an extra mile to go into the communities to identify those who are suffering from obstetric fistula, and then inform us, and also to encourage them that they can be repaired.
Right.
So when we identify them, we transfer them, as I've already said. Now we pay for the people we send to the hospital for repairs. We pay for their costs. And we also reintegrate them into society by giving them some package for them to sustain on it. So this is what we do to support the whole program on obstetric fistula.
Right.
We also serve. Hello.
That's okay. You were saying.
Yes, we also serve on the National Fistula Board, and we are also a member of the National Task Force team. This is what the ministry does, and for what we have done, we can say that we have been able to bring back hope in some of the women and girls that we have identified.
Right. You are saying that it's difficult to even identify them, but for those who may be watching and decide to approach the ministry, what's the channel? How can they access you?
They have to call our helpline of hope. Maybe some are not aware. The ministry has a helpline of hope, where all sorts of cases, all sorts of issues are channeled to us. All you have to do is to call the toll-free line, that is 0800 800 800. When you call the toll-free line, whatever your case is, it will be recorded and referred to the appropriate department or unit to handle. So I want to encourage anybody who is anywhere suffering from fistula to call. It is when they call, when we get into contact with them, that we will know that we have this kind of number. As we speak, it is only Upper West who was able to tell me that they have about 4 women who need care and support. Right. And also the Department of Gender regional offices are at all regional coordinating councils. People can go there and report cases of fistula that they are aware of. Even if it is the sufferers themselves or a good citizen who comes across a case like that, who goes there to report, and we are ready to see what we can do to restore self-worth in that person.
What happens to traditional birth attendants, for instance, and people within the rural communities who may still not understand the need for a woman who is due to give birth to go to a medical facility? What happens to them? What's the plan?
With them, I don't think we really have any plan for them, but they are invited to some of the sensitization programs, the community engagements. And you know, when it comes to the medical briefings, the medical talks, it is the Ghana Health Service officers. They are the ones who give that talk. All we do is to facilitate and to make sure that information reaches all of them. We don't have any direct role with traditional birth attendants. I think that is an exclusive area for Ghana Health Service.
Right. Thank you so much, Dr. Comfort Asare, for joining us. It's always a pleasure speaking to you. Dr. Comfort Asare is the Director of Gender at the Ministry of Gender, sharing with us what the ministry itself is doing in terms of interventions. We'll be joined also on the phone lines shortly by a fistula survivor who will share her experience briefly. She will communicate with us in local language P, and I'll speak to her and then interpret it. However, we now know that the Ministry of Gender has a helpline of hope. If you have any issues, it is 0800 800 800. Call that line and have your issues addressed. Before we bring in the survivor, and I'm hoping that we are trying to get her on the phone line so that we can do that quickly, there's another part of this that has got to do with stigma.
Yeah.
For instance, the persons who, I don't know whether to call them perpetrators, who push women not to go to the facilities, and they see them struggling, but they still make them go through that process and they end up developing the condition. What can we do to change their mindset?
Yeah, that's a very important question, and sometimes it's the reality of where the woman lives.
Okay.
Yeah, and it's not also so much about perpetrators per se.
Okay.
But it's just that for where she stays and what the practices are, that is their reality. So here you need the traditional authorities, the community leaders, the opinion leaders. They have to be brought on the board, the sensitization and awareness of the dangers in trying to deliver at home or not going early enough to the health facility. We do have lots of people who are still delivered by the traditional birth attendants, and they are not considered one of the skilled attendants at birth, because often when things are going wrong, they don't see it. But if you live where you don't have ready access to a health facility, or the tradition is just to deliver or be delivered by the traditional birth attendant, it's extremely difficult for the woman to go contrary to that norm. So we need to bring traditional leaders, opinion leaders, community leaders on board, and not just a gender ministry and Ghana Health Service role. Right.
We'll now hear from a survivor of fistula. We cannot, of course, disclose her identity, and she's talking to us by phone in Tree. Good afternoon. Yeah, that's it. What is saying, Pacho?
But I'm not a clear.
Miss me who ye, that's a pass away to me, fraying. Now, one ma say ye no casa. Me pesa wo ka nia wo femu anadia wo femu no a cheye mba ma mbisa ansa pacho o ma hwe wo sisi a wo ye okay
Me pacho an for 2 years.
Okay. Pacho so obetimi a ka nia wo femu cheye
Pacho yo. E da se now at the point. Me pacho 2000 and I walk on I was a palanque and water. It's on the Simona. Yes, I'm thank you. It's in a maybe 2 weeks time. And
Auntie, hello, Auntie. You should until ye into Jina ye na sa shas ye biom na yentie.
Pacho is
Dabi san twa ho kakra.
Pacho ye.
Sisi ade ye yen kasa.
The Pacho is 2010. And I walk to the company. The sun can't fly. In 2 weeks time. And I'm going to 5 years.
Hello.
Yes.
Meet you.
Just about 1 year. Now the way I facility, I found the one to learn. I pass and I want to make sure that they are simply what a
lot. Enti eye osano o manage o say. Right, it appears we unfortunately lost her, but that is a survivor of fistula. She tells us that she has received treatment. She talked about how it started and how it had been affecting her. We have her back on the line. Hello, Auntie.
Yes.
Oh. Na minti papa. Inti na wo kan.
The passion that makes it a that one is the now what
yo sesiano se ye ma wo chance se obi a je se offer dia wo fe bu na kasa che na den na obeka che no
the passion never nobody on fire no how to go wow say when you did part of it na be ko for the bank. Yes, I but the it's good fun.
Well, thank you so much. We did try. The phone lines didn't help us too much, but at least what we gleaned from that conversation was that she talked about the fact that urine was uncontrollable and she would buy a diaper, and the day she didn't have money or she couldn't afford, then she couldn't buy one, and how difficult it was, and how happy she is now that she's gone through the treatment, and she's urging anyone else who is listening who has the condition to also try and seek help. Thank you so much, Auntie. Se utiemia yeda se pa se witimi a share with experience at training. So that's about her experience. Let me just bring in some of the comments that are coming in, Doc. Someone says, hello, Sally, and good day. You're looking very great. Thank you. And you're treating a nice topic. My suggestion is our hospital should inculcate these topics into our antenatal lessons, because I never heard any discussion on fistula during my antenatal visits at the hospital. Again, since most people in the rural areas visit the traditional birth attendants, there should be a way to get this message to them, since they are at higher risk. Jennifer from Mataheko sent that one. This one says, please, can a woman give birth normal at age 47? My name is Nusi Fafa, and what are her chances? From Tamale. Thank you.
Can I address all?
Yes, you can.
At 47, we will not recommend that she delivers by herself. There are many reasons why, and it would be nice to have a discussion with your physician or obstetrician regarding this. But as a principle, we do not recommend 47-year-old delivering by herself, especially the very first child.
Yeah. What about the first issue about antenatal classes?
That's a very good suggestion. That is worth looking into. It doesn't feature in the antenatal school education, primarily because I guess we are assuming that those who are listening to us will come back to deliver with us. We do often forget that not all of them will come back. And some of those who do not come back end up in fistula. So yes, it's a very good suggestion to be taken on board.
Someone says, good afternoon, this is Benis Pobley. This is my first time watching your program. I guess I've missed a lot from the previous ones. My question is, can piles cause obstetric fistula? And my second question is, does obstetric fistula occur in the process of pregnancy or after childbirth? And I also want to ask about those of us who are single and not pregnant. What are the risk factors some of the activities can cause? Looking so classy. Okay, thank you. Let's get to it. She talks about whether piles can cause obstetric fistula.
Piles will not
cause that. And then she says the process of pregnancy or childbirth, can you know even before you get pregnant?
If you are shorter than 1.5 meters, then there's a likelihood that you may not be able to deliver the average sized baby normally. So your height is a first check.
Okay.
And then subsequently, if there are any problems with the baby, antenatal care will show. Yeah.
And she comes up again, so I'll just read it out. You're looking so classy, Selikem, and thanks to the doctor for educating us. Okay, but that does it. We ran out of time.
Okay.
Doc, what would you, in your final comments, want to hamper on?
I think we need everybody's hands on board. We need everybody on board. The fistula is a hydra-headed problem. I mean, the factors are many. Yes, it's cross-cutting issues. Multi-sectorial effort is required. At the local government level, at the Ministry of Education level, finance level, chieftaincy, religion, we all must put our shoulders to the wheel. It is not also a good idea to leave it to government. I don't think government alone can end fistula in Ghana. We need everyone's hands on deck. We need everybody's effort to get fistula out of Ghana.
I didn't even ask you, as a fistula surgeon,
yes,
your experience.
It's very humbling, and if you don't know or you've never known how to count your blessings, visit a fistula treatment center. You see how lucky you are.
And then finally, what nagging observations have you made?
The stories are the same.
Right.
The road that leads to fistula runs through almost all the cases. Labor became difficult. They couldn't get immediate access to hospital, and they get fistula. It's like once they start, you know how it will end. And the solution is not far-fetched. It's not rocket science. It's all about commitment to it. It's all about getting many people interested. It's all about all of us determining that we want to end fistula. It's a clear violation of the rights of these women. Serious human rights violation. Because the right to access to health, it's also fundamental. And for the universal health care package, we say leaving no one behind.
Right.
And we want to start from the farthest behind first. And we're leaving fistula patients behind. So at the end of the day, really, what are we doing? Chanting the slogan of leaving no one behind, leaving no one behind, when we're actually leaving fistula patients behind all the time.
What would you recommend, though?
We do seriously need a national dialogue on obstetric fistula. Right from the top, whoever is keen, listening, Ministry of Health, Minister of Gender, Ghana Health Service, we need a roundtable discourse to root fistula out of Ghana, and we can do it.
Thank you very much, Doc, for sharing your thoughts with us, and it's always good to have you. We know you're a busy person, but you make time to come around. Thank you once again for the education. And you heard Doc Gabriel Ganyaglo over there. He says that, look, this is a multi-pronged approach, and we should not leave anyone behind. He is a fistula surgeon with the Korle Teaching Hospital and has been my guest today. We were also earlier joined via Zoom by the Director for Gender at the Ministry of Gender, Children and Social Protection, Dr. Comfort Asare. Thank you so much for joining us in the conversation, and also our fistula survivor who called in to speak to us, Auntie. Once again, Yedawa Sewai. Thank you all to you who sent in your comments and questions. We'll do this again another time. My name is Selike Makolachi Palu. I was produced by John Amemo and of course the entire team here at GBC News. Have a good evening.